Welcome back to Fertility Fact or Fiction, where every week we get a chance to discuss an important hot topic, and we are going to tell you whether it's a fact or a fiction and help you with your fertility journey. And as well, we take all the questions we can live. We're on for an hour, and we are really glad to have you with us. This week's topic is based on a recent study from Fertility and Sterility, one of the main journals that we use in the fertility world. And it's basically on a very novel and interesting approach to helping women who don't have the ideal number of eggs retrieved in a single cycle. So in any given cycle, typically in a normal IVF approach, what you do is stimulate the woman in the early phase, which is the follicular phase. So this is right after you've started your menstruation, and you are giving them medication, whether it's oral medication or injectable medication, to try and stimulate the ovaries to produce eggs. And once you've started producing those eggs, you grow them, you monitor the growth of the eggs, you get them to the point where it's ready to trigger because they're now mature. You trigger the release of the eggs, and then you go and retrieve them sometime usually between 35 to 37 hours later. So with this Duo Stim, what they suggest is after you've done that first follicular phase stimulation, you want to go and do a luteal phase stimulation as well. Now here's why they think that that's a reasonable idea. In any given cycle, there are actually what they call waves of follicular recruitment. In other words, it's not all done just at the start of your period, it's actually done potentially multiple times throughout your cycle. And because you're recruiting and potentially growing eggs at different times, the suggestion is maybe you can capitalize on that and improve the success rate in a short period of time using a back-to-back stimulation protocol. Here's the theory why that may be helpful. So if you look here, this is FSH in the blue and LH in the green, and you can see that with the FSH, as it begins to rise, it dips down and then spikes up and then goes back down. So there's this initial rise, then it drops, then it spikes. So this secondary spike is thought to be the start of a secondary recruitment of follicles. And because you're recruiting those follicles not once but twice, you may actually be giving yourself a better opportunity to get more eggs. So they've named this Duo Stim just because it's two stimulations. So the question has become, does this help? So there was actually a recent article, as I mentioned, Infertility and Sterility, and there was a previous but very recent as well meta-analysis of this topic. So in the most recent article, Infertility and Sterility, they compared two groups. One was patients just doing a follicular phase stim, so that's your normal first stim, like in your normal IVF approach, versus doing the Duo Stim approach. And this was generally for women who had poor response previously per this specific set of criteria referred to as the Bologna criteria. So when they did that, what they showed that was that in the study group that did the normal approach, the follicular phase only stim, they had a 7% live birth rate, which is obviously not only devastating, but considerably low and concerning for anyone going into this. But in the Duo Stim group, they actually more than doubled it and had a 15% live birth rate. And for those of you that follow our posts, you will know that I just recently posted about this. I was so excited about it, I really wanted to delve into it a little more. So I thought that it would be a great topic for tonight. So it does look like it could be very, very useful. So I went into the meta-analysis study, and I've got the results for you. I'm going to have to read, so forgive me for looking down, but the meta-analysis results are really quite interesting. So in a meta-analysis, what they do is they take all of the studies that have previously been done, they kind of mash the data together, and then they give you a response based on what they're seeing from not just the one study, but numerous studies that are pooled together. Now, it is subject to some problems, including things like what they call heterogeneity, where one study is done one way, the other study is done the other way, and as a result, you're not getting ideal ability to mix the studies together. together. But overall, you get a stronger response. And so you get a better statistical analysis of the results because it gives you a better idea of whether or not the findings are really genuine or they're just kind of not really realistic or applicable clinically. So the first thing they looked at was the stimulation protocols. So what they mean by that is, did all these studies use pills or shots or pills and shots? And the answer was there were numerous different studies that they examined, in some cases about 10 studies altogether over the last several years. And when they looked at those studies, they showed that it was very variable. So some authors or research centers used the pills, and that could be either Clomid or letrozole, while other places use the injectables. And most places are using injectables, but there are places, especially for poor responders, who just use pills like Clomid or letrozole. So it didn't really make a difference which one you used, but they were all available. The second thing was how long it took for patients to stimulate in both the follicular phase and the luteal phase. So it was roughly the same, anywhere from about 3.9 to 10.8 days of stimulation, and that was the same sort of in both the follicular phase and the luteal phase groups. But they thought that there may be a tendency to take a little bit longer to respond in the luteal phase, so that's your second stimulation. And the actual protocol is do your normal follicular phase stim, wait 5 days after the egg retrieval, and then immediately start another stimulation protocol. So the first one took anywhere from 3.9, which is very short, up to 10.8 days, which is pretty average. And then in the second phase, they had the same sort of outcome as far as duration. But overall, they said that when they looked at the numbers, it did look like it may take a little bit longer in that second response. Cycle cancellation rate they looked at, it was very variable, and this is really important. So keep in mind, if you're a poor responder, the Duo Stim protocol certainly presents a lot of hope, but those numbers are not robust. They're still very modest, okay? So cycle cancellation rates were anywhere from 4.8, which was very low, up to 52.6% in the follicular phase, and from 3.3 to 43.3% in the luteal phase. So even though this appears to be very helpful, there is a potential that you won't respond as adequately or as strongly as we want, and there may still be cancellations, which can be experienced with any patient that's a poor responder during any cycle. The next thing they looked at was how many eggs did you produce? So was the egg number the same between the two cycles? And the interesting thing here is in the most recent study that was published in Fertility and Sterility, they did demonstrate that it appears that you're definitely getting more eggs. Obviously makes sense. You're doing 2 retrievals, so you should end up with more eggs. But in this meta-analysis, they also showed that the egg number tends to increase a little bit from the follicular phase stim to the luteal phase stim. In other words, in your second stimulation, you're actually getting a higher number of eggs than you typically do in that first stimulation. So that's kind of interesting. No one's ever really talked about this too much, and this is kind of novel theory. The question is being asked then, is that second wave of follicular recruitment potentially stronger or better than the first? And the answer is yes, it does appear that the second wave actually may have more eggs, which is super beneficial for our patients. What about the number of mature oocytes or eggs? So keep in mind, when we do an IVF cycle, we really need those eggs to be mature in order to be able to fertilize them. Immature eggs don't do nearly as well. So when we looked at the number of mature eggs, they actually think that there may be even more eggs in the in the luteal phase, so again, that second stim, than there are in the first. Embryology data, they're showing no difference. So the number of top quality blastocysts, the number of blastocysts you actually get, the number of embryos that are euploid, meaning genetically normal, same between the follicular phase stimulation group and the luteal phase stimulation group. So again, very robust, important data. Your egg number may be higher, you may get a few more embryos, but the reality is that the outcomes appear to be about the same in both groups. You're just going to end up with more when you do 2 back-to-back than you are when you do just 1 alone. Fertilization rate was quite high, anywhere from about 73 to 87% on average. So the fertilization of the eggs was quite good in both groups. clinical pregnancy rate was incredibly variable. And here's where I start to worry a little bit, because the low end was 10.7, which is kind of modest and in line with what they saw in that more recent study with fertility and sterility, but the high end was 85.7%. So to take a poor response group and get an 85.7% clinical pregnancy rate, which means we saw the baby's heartbeat on ultrasound, is pretty unusual, and I'm kind of skeptical about seeing results like that because they're not very realistic. So probably taking a much more conservative approach to this. It does look like we see modest success rates. How high they are, we got to be really cautious until we have a much larger randomized controlled trial, but it does look like there is some promise here. Very similar results when they looked at live birth rate, anywhere from 10.3 to 71.4% success rate. So again, very, very variable. The 10.3 seems pretty clear and certainly believable, but it's low. The 71.4%, that's a high success rate in general. So to take a poor responder and end up with that success rate is probably not very realistic, and you have to kind of delve into that data and see specifically what they did in that study. The last thing they looked at was miscarriage rates, and the miscarriage rates were again variable, anywhere from 0 to about 25%. Now, a lot of these studies actually did use pre-implantation genetic testing because the patients were frequently older. The mean age in the more recent study was around 42. And so when you're looking at that age group, PGT, as I've discussed before, does probably make sense because you're over the age of 38. And in that age group, there is some evidence that supports doing the pre-implantation genetic testing. So miscarriage rates are probably a bit lower because you're less prone to getting a genetically abnormal embryo implanted, and so you're less likely to having a miscarriage rate. So the fertility factor fiction for this week was, does the Duo Stim protocol work? And the answer is yes, it does appear to work. It is a fact. If you're doing a back-to-back cycle, you are getting the benefit of doing 2 waves of follicular recruitment, and that can then lead to a higher number of eggs, a higher number of embryos, and a better chance of you getting pregnant. How high of chance? That still needs to be worked out in detail, and I certainly would caution all of you that you got to be very, very realistic about the numbers you're expecting, but it does look very promising compared to what we've had before. It's a doubling of what they themselves saw in the study that they did recently, and most importantly, this is going to compress the time for those of you that are rushed because age or your follicular, sort of follicular genesis is compromised, or even for those who, for example, are going through cancer treatment and need to do 2 cycles at once in order to get as many eggs as possible before they're being exposed to chemotherapy. So yes, it is a fact. It does look like the Duo Stim may be helpful. So thanks for joining us for that part of the fertility factor fiction. We're going to take some questions now, and I think we can probably go to the questions that were asked of us first on Instagram. So Tarek's going to read out some questions. I may repeat them just so everybody's on the same page.
Right. The first question, again, it's not my question, but my breasts throb from ovulation to period. Does this indicate anything?
Actually, somebody asked that last week as well. So not really. I mean, breast changes do occur during your stimulation cycle in response to estrogen and progesterone changes. So there's certainly some changes that are hormonal, but the reality is that those hormone changes don't necessarily indicate anything specific, just changes in your estrogen and progesterone level.
Next question. What kind of tests should be done when there's male factor to discover the root cause, especially with low volume and count?
Okay, so that question is, what sort of tests should males undergo to figure out what's going on if the sperm sample is not optimal? So there's a whole host of tests, and it really depends on how bad the sperm is. The common starting point would be a semen analysis, and then looking carefully at all of the main parameters. So the sperm count, the percentage of sperm that are motile, which we refer to as motility, the percentage of sperm that are moving quickly, that's progression, and then the number of sperm that are normal or abnormal. More advanced tests, in particular, if there's very significant problems, you may need hormonal tests. You may need a scrotal ultrasound to rule out things like a varicocele, which is kind of like a varicose vein, but it's around the testicle, and that can overheat the testicle, cause compromise. There are genetic tests we do for certain men. And then the most important thing that's really up and coming is whether or not sperm DNA fragmentation is important. And it does look like it can make a difference in certain cases. So we're going to be doing that here. For many years I didn't, but now I actually have become a bit of a believer. In the right circumstances, it's probably appropriate. We do know that it looks more and more like it's affiliated or associated with outcomes, including miscarriage risk, and maybe even the quality of your embryos, the number of embryos you produce, and so on.
Next question is, what is a good AMH level?
Okay, so AMH, a good AMH level very much depends on your age, and it depends on which units you're using. So typically most centers are using picomoles per liter, but there are some that use nanograms per mil, and it's quite different between the two. So don't panic, because when I say the number for picomoles per liter, you want to make sure that that's the number you're thinking of, the units that you're thinking of, because it's much, much lower when you're doing nanograms per mil. So in a picomole per liter, we know that if you're less than 2, you definitely are going to be facing significant compromise. The majority of studies that have been done show virtually no success when your AMH is less than 2. Keep in mind, I'm choosing my words carefully. There is always a chance. So even if your AMH is super low, less than 2, you do still have a chance, but it is definitely compromised, and it will be difficult in that stage to help you. If you are between 2 and 5, we know that typically you will not be producing a lot of eggs, but you still can produce some. Most people are going to produce somewhere between 2 to 5 or 2 to 6 eggs in that range. Anything over 5 is generally considered normal, and anything over 25 is considered high. So that's typically what you'll see in patients who are much younger, or they have something like polycystic ovarian syndrome.
Do you need to be on Clexane on day of transfer if you have antiphospholipid syndrome?
So that question is, do you need to be on Clexane, which we figured out in a previous fertility factor fiction is a anticoagulant, like a low molecular weight heparin, on the day of your embryo transfer in order to make it successful. So a lot of studies actually looked at starting heparins later when you have a positive pregnancy test. I'm actually a very firm believer that those are wrong and that it needs to be started at the time of transfer. The reason for that is, number one, heparin is a strong anti-inflammatory, so you're getting the anti-inflammatory benefit of the drug when the embryo is implanting, and that's important for many people who do have a lot of inflammation in their pelvis or in their endometrium. The second part of it that's important is that the heparin actually prevents blood clots, and it's in those early stages that the embryo is forming its attachments and its blood supply. If you have a tendency to form blood clots, you can clot those very small microvascular connections off early on, and if the embryo is not getting the oxygen or blood supply, including glucose and nutrients and so on, that it needs, it's definitely going to find the opportunity to say, hey, this is the wrong environment, I can't continue here, and that's where you suffer either a very early miscarriage, or unfortunately you're getting what's called a chemical pregnancy, where we see the beta HCG rise initially and then it rapidly falls off before you even get to the point where you'll see anything on ultrasound.
Got a question, advice on birth control for PCOS and period regulation and having endometrial hyperplasia, PL.
Oh wow. Okay, so if you have PCOS and you have endometrial hyperplasia actively, you actually need active treatment for that. So that's high dose progesterone to make it regress. Although the newest guidelines suggest that if you have endometrial hyperplasia without atypia, which is the predisposition to cancer, then you can manage it just with conservative treatment. So maybe even the pill would be okay. If you have endometrial hyperplasia with atypia, you actually absolutely have to be careful and be on this high dose progesterone. It's called Megace. That's the stuff we usually use, and that's a very strong progesterone. You need to be on it for at least 3 months, then you get rebiopsied and make sure that the hyperplasia with atypia has regressed, because for patients that have hyperplasia with atypia, the coexisting, meaning actually you already have it, cancer rates can be considerable. So those patients cannot be on the birth control pill because there's estrogen in it, and that's what's causing the hyperplasia to begin with. For patients who do not have atypia and just have PCOS, you want a very anti-androgenic oral contraceptive pill. So the two that are most anti-androgenic are either Yaz or Diane 35, and those are your best two choices.
Before a FET, does your team monitor hormone levels to make sure you haven't ovulated naturally?
Yeah, for sure. So many of our patients are actually on a drug that will suppress them from being able to ovulate naturally. So we use a lot of GnRH agonists such as Lupron, and that can prevent you from ovulating naturally, but we do monitor your hormones. We definitely monitor your progesterone levels. We're bringing you in and monitoring number of eggs that you have. What does your lining look like? We're really very, very fastidious about the pre-embryo transfer monitoring to make sure that everything is like picture perfect for you.
And there was one more question. These are just the advanced questions.
Yeah, these are all the advanced questions.
You got tons coming. It's more of a comment. Thank you for all the wonderful work.
Oh, well, thank you to everybody that's saying thank you. So that's real easy. Are you going to be asking the Facebook ones? Because I can do the new Instagram ones from here. Do you want to flip to Facebook and then you can ask me from there? That'll work better.
Yeah, you want to go give some? Okay. Sure.
I'll do the Instagram ones and you look up the Facebook ones. How's that?
Yeah.
Okay, so we've got another question from Instagram, which is, will we be doing Duo Stim for our patients? And the answer is yes, for sure. Once the Windsor Clinic is open, which should be very, very shortly, we will definitely be offering this to patients. The problem with it is, on our end, that we're actually duplicating all of the process, and so we have to figure out a cost that's going to work. I hope I haven't misled anybody. The one warning with all of this is the cost is going to be considerable because you're basically doing 2 back-to-back IVF cycles. We don't really have a mechanism by which we can save you a whole lot of money because all of the instruments, all of the equipment, all of the supplies that we use literally have to be duplicated. There's no holdover from one cycle to the next. So the costs are going to be substantial. I'm certainly happy to take a bit of a cut in what we get, but that's only a small part of your overall IVF costs. So I'm not sure what the overall cost is going to be. We're definitely going to try and make it super, super available to our patients. That's our first priority, but we are kind of figuring out the costing for that right now, and I've been in discussions with our business manager to come up with something that's ideal for you guys. You got one from Facebook?
I had my embryos tested and one came back as mosaic, 40% or less abnormal cells, trisomy 19. Would you transfer an embryo with this? It's our last one. I'm not sure what to do.
That's a fantastic question. So I'm sorry you're stuck with that. That's definitely a hard thing to decide. So that's something you need genetic counseling for. Certainly when you have higher level mosaicism, and it varies depending on which author you read, anything from 10 to 20% is considered low, and when you're up in the 40s, you're probably into the higher levels of mosaicism. The chance that that embryo will be normal becomes less and less. So I will certainly transfer whatever embryo you guys tell me to transfer, because I'm a big believer that you should have your own autonomy, and as long as we've done our job in informing you and giving you the best information, the most up-to-date info, the best knowledge possible, that really you're best capable or best suited to make a decision that's right for you. Would I do it if it was my own family? I mean, it really depends on what you're anticipating and what your comfort level is with the outcomes. So let's play that out. So number one would be you get pregnant and then you end up having a completely normal pregnancy. Hallelujah, that's awesome, right? The second scenario would be you get pregnant, but at some point in the pregnancy, they determine that the pregnancy is abnormal. Trisomy 19 is probably not compatible with life. And so now you're faced with either continue the pregnancy until it unfortunately either expires in utero, or terminate the pregnancy, which for some people is not an option because of religious and moral feelings or sensitivities, okay? So, or beliefs. So definitely that could be a problem for some, and you need to gauge that and the importance of that for you when you're making this kind of decision. The third possibility is that you get pregnant and then you miscarry before it becomes a problem. And then obviously the fourth one is it just won't work. So in some cases, if the embryo is abnormal enough, it's just not going to implant and take. So the one that I would focus the most on is what happens if it does implant, but it becomes an abnormal pregnancy, meaning you find out that the baby is genetically abnormal. You got to determine what your comfort level is with the next steps, being either continuing with the pregnancy or termination. If you're comfortable with whatever decision you're going to make, yeah, I mean, I don't see why you wouldn't use your last embryo, especially if it's your last one. If you're not comfortable with that, then come and see us and let's talk about alternative options for you. You want me to take an Instagram? We're going to flip back and forth. If you breastfed for 12 to 13 months, when should you expect your period to return and when should you worry? Note, I was never regular before having children. Okay, so if you're not regular, I say this over and over and over again, that is worrisome because your estrogen levels are typically high, your progesterone levels are typically low, and you are at risk for developing endometrial hyperplasia. So please remember, you cannot be irregular on your own. If you're on medication and you're irregular, like the birth control pill, that's fine. But if you are irregular on your own, you are predisposing yourself potentially to cancer of the uterus, endometrial cancer. So you cannot be irregular on your own. Typically, after you're done breastfeeding, sometime within 6 weeks to 3 months, you should resume normal, regular menstrual cycles. If you're not, you should be seeing your physician. Simple hormonal testing will figure out what's wrong. And please, please, please remember, do not be irregular on your own. That is not safe for you long term.
I'm scheduled for laparoscopy with you for unexplained infertility after trying IUI without success. The surgery is on the day that I'm expecting my period. Would that affect the surgery? Should I reschedule when I'm not on my period?
No, don't worry. It's not going to affect the procedure because we wash out everything inside your uterus when we do the hysteroscopic portion of the procedure, so I'll still be able to see. And the laparoscopic portion of the procedure, which is where we're looking inside your pelvis, is not affected at all by whether or not you're on your period. In fact, in some cases, it's kind of interesting to do it then because we can see if some of the blood from your period is actually going back into your pelvis, which can predispose you to endometriosis. So it's actually kind of useful for us sometimes to see it in that circumstance. So don't be uncomfortable at all. And definitely, you're obviously Canadian because I'm operating on you. Do not cancel your surgery because it is so difficult to get surgical time. The last thing we want to do is have you cancel your surgery. So, you know, something that's not really commonly understood in Canada, surgery really is not something that any fertility specialist does because it is profitable. In fact, it's a huge financial loss. I do it for my patients because I think it's really important that a fertility specialist look inside them and help figure out what's wrong. It's definitely with a different set of eyes that I'm looking at things on there. Okay, we're back.
Yeah,
So yeah, definitely do not cancel your surgery, and you being on your period has no impact whatsoever. My turn, I guess. Oh no, your turn. Yeah.
Does the current funded IVF list still exist now that you have stopped doing IVF in Toronto? What will happen to the people who are still waiting on funded list?
Yeah.
Thank you for all you do.
Thank you for being a patient and asking the question. And thanks to all of you for joining again as usual. So we are in negotiations with a very large fertility center in Toronto, and we are in negotiations with the government in order to get funding here. So I'm going to try and acquire some funding in Toronto, and I'm also trying to acquire funding for our Windsor Center. We are fairly confident we're going to be able to manage both of those, and so we are working really hard on that. So I am maintaining the list, but whether or not we can get access to the funding is a different question. Give me just one sec, folks. Is that Windsor Regional calling?
They had called.
Okay, I'm going to have to call them back because we're going to need to see what they wanted.
And that's nothing.
Oh, okay, that one you can cancel. Okay, so I may take just a brief pause, folks, just because I got to answer a call from the hospital, but I'll be back with you in a sec. Or Tarek, do you want to just call them back? Just call Emerge at Windsor Regional and see what they asked for. It's 52289. Sorry, folks, I'll take some Instagram questions in the meantime. When your patients are put on heparin during frozen embryo transfer, do you continue aspirin as well? So it all 52289. It all depends on what the reason is and what's going on. So just go over there. If you're on it for antiphospholipid antibody syndrome, yes, you need to be on aspirin and heparin. Otherwise, we usually use both, but you don't actually have to. And there is definitely an increased risk of bleeding when you're doing both. So we do see some patients who come in panicked because they're bleeding, and sometimes we have to stop the aspirin and the heparin until the bleeding settles down. So I do use typically both, but it depends on the circumstances and the patient. Okay, we have our frozen embryo transfer Thursday, yay. Just so we can prepare, what are the odds that this will turn into a live birth? I'm on all the meds, prednisone, estrogen, PIO, embryos AB. Again, it very much depends on what the age is, whether the embryo is genetically normal or not, which sometimes we know and sometimes we don't. So there's no way for me to answer that. I can tell you in general, overall, our success rates have been somewhere between 60 to 70% per cycle. So we generally are able to get the majority of patients pregnant with one cycle of IVF. Sometimes we need more than one, but as an overall sort of picture, we do very, very well when we're doing IVF for our patients. So hopefully that answers that question. What should we see at a 5 weeks and 3 days scan? If you're doing a dating scan, so you think that you're pregnant or you have a positive pregnancy test, and you're trying to determine whether or not there's something there, we actually recommend you not be scanned that early because it is not of much clinical utility to you. So I definitely would recommend that you do the testing after 6 weeks when we know that we should be seeing a fetal pole, meaning the actual fetus itself, and a heartbeat should be visible at the 6 week and 1 or 2 day stage if you have a top quality ultrasound available. So at 5 weeks, 3 days, if you're lucky, you might see a small sac in the uterus. That is really all we would expect you to see at that point in time. Okay, let's see if I can, if we wanted to come see you, but I live in Cambridge, would you say this is too far for all the appointments I need? No, we take patients from all over the place. I've had patients from Ghana. So we can manage things no matter where you are. You don't have to do all your testing with us. We do like it when patients do their testing with us, but it's not critical and it's certainly not mandatory. You're free to do your testing wherever. So I'm happy to see you, give you guidance, give you advice, set up the testing for you. You can take our requisitions, use them in Cambridge, and when you're in Cambridge, they'll get us the answers and they will forward them to me. You would just then come back to see us for visiting and figuring out what's going on. Let me see. Another Facebook question. No, we're good there. Okay. Back to Instagram. If your placenta is low and you're restricted from intercourse, is it still safe to be sexually active with your partner? Wow, I guess that's like the Bill Clinton definition of sexually active, guys. So if you have a low-lying placenta, meaning it is within 2 centimeters of your cervix, then it is really important that you not have anything go in the vagina. And for those of you that are planning to get creative, that's 360 degrees around the vagina. So that includes rectal intercourse, vaginal intercourse, fingers, tongue, anything else, toys, whatever. So everything is off limits from basically your belly button down to your mid-thigh. Now you can have external stimulation, like clitoral stimulation, but nothing can go inside the vagina because unfortunately you can actually start some pretty torrential bleeding and that can be harmful to you and to your baby. So I hope that answers that question. You can certainly do anything to your partner that you want, be as creative as you like, but the female partner or I shouldn't say the female partner, but the pregnant partner should really not be receiving anything going into the vagina. Is there any way to increase your AMH level or at least keep it from decreasing faster? That's a great question. The science is still not really sure on that. So we do use some tricks to try and improve the number of eggs and in some cases the number of embryos that you're producing. So some of those tricks are things like coenzyme Q10 to improve egg quality, lots of vitamins, which we've discussed on this show, especially with our great naturopath, Dr. Jennifer Strong. Definitely reducing stress. Some of those things can help improve your egg production and egg yield. The other thing that's pretty pretty important is either using a hormone called DHEA, which can increase the number of eggs, but not necessarily the number of embryos, as well as doing growth hormone. Now, I've tried growth hormone and didn't see a huge amount of success with it, but the most recent data actually suggests that it may even increase live birth. So certainly for patients, for example, who are doing this Duo Stim protocol, you want to try and maximize what you're getting out of it. There may be specialized protocols we apply to these patients to try and really get the most benefit we can for them. But we don't actually know if there is any way to increase your AMH. As far as preventing it from decreasing, obviously, the number one thing is avoid exposures to things that are harmful. Drugs, alcohol, smoking, radiation exposure, chemotherapy exposure, which certainly none of you are going into unless you absolutely have to. So the lifestyle things are really important. You do want to maintain a reasonable BMI, you want to maintain a healthy lifestyle, and you do want to minimize your stress level as much as possible, because all of those things can lead to a decreased AMH. And a very low BMI can also lead to problems as well. So you don't want to be excessively thin, and you don't want to be excessively over the ideal BMI. You want to be just in the right range. So hopefully that answers that for you. You got one from
I got
Facebook?
So many, but the Facebook only keeps the top 5.
Okay.
As soon as more than 5 comes in, then it's gone. So you have to.
Okay, sorry, we had to take an important call from the hospital. My apologies, guys. Yep.
So I'm a 38-year-old unexplained. Oh, it's gone. Okay, the next one. Can we still use the pharmacy at your client's clinic if we are not your current patient? Always a Dr. V patient. Thanks for everything. You are the best.
Oh, well, thank you for the kind comments. And yeah, you can absolutely use our pharmacy or any other pharmacy, not a problem. There's no restrictions on which pharmacy you use. It's actually against the law to force you to go to a specific pharmacy, and we never do. We certainly recommend ours because we have the most amazing lead pharmacist and associated pharmacy techs there. They're incredible. They're very committed to our patients, and they know everything there is to know about the fertility drugs, so we really love them. They've even been active sourcing a special device and medication all the way from Germany from one of my patients that's really struggling with their health. So we have a crack team that just really demonstrates the best qualities available in a pharmacy team, but you can shop your pharmacy anywhere you want, and so don't hesitate. Whatever is convenient for you, you should do. I think I have some of the questions here. Do you want me to? I do? Oh, I have them all. Okay. If I'm currently in, oh wait, sorry, I missed one. Which way are we going?
There's a bunch down.
Are they? Okay,
Yeah,
wait, let me go this way. Let's see here. Can we still use, will IVF be less expensive in your office in Windsor? I'm certainly trying to make it so. I actually want to get some feedback from all of you, so this is a great opportunity to ask, and I'm going to post this. But one of the models that's being suggested to us, yeah, make sure you comment on this one as much as humanly possible. I literally want all of you to type in an answer. So one of the recommendations is that instead of just charging you kind of a blanket or a bundle balloon fee for your IVF cycle, that we actually do it in a system that is kind of back-loaded instead of front-loaded. So let me explain what I mean. So typically when you're doing an IVF cycle, you just pay up front. Doesn't matter how many eggs or embryos you get. You've paid for it up front. Whatever the outcome is, it is. And then you go and do your embryo transfer. And there's a specific cost associated with your frozen embryo transfer, especially if you're doing frozen embryos. One of the suggestions that was made to me recently is backload it. So in other words, we charge you a minimum amount for your actual IVF cycle, and then we charge you per embryo for freezing the embryos, and then we charge you per embryo transfer, but obviously a little bit more for the embryo transfer, so that if you have just 1 or 2, you're not going to pay as much, and certainly if you have 3 or 4, you're going to be paying a little bit more. Now, ultimately, it'll probably all average out the same, but at the start, it would be much more manageable for a lot of our patients. So I'm really, really intrigued by this. It sounds like a really novel idea. Nobody is doing a backloaded IVF fee schedule. And so I want to hear from you guys. Let us know what you think of this, yay or nay. I want to know if you think that backloading the cost, making the FET, the frozen embryo transfer, a little bit more and charging you per frozen embryo and per frozen embryo transfer would be better for you, and then charging you less for the actual IVF retrieval and stimulation and monitoring. So we are going to aim overall for lower costs for sure. That's a big part of what I want to do here, but we also want to know what kind of fee structure you guys think would be ideal. Let me take one of these. How do you, let's see here. How do you increase your sperm count to be healthy? Okay, so this is a common question. We've answered it before, but I'll do it again because it's an oldie but a goodie. Okay, so number one, healthy living. No smoking, no drinking, no marijuana. All three of those are known to be detrimental to your sperm performance. Number two, if you are overweight, you want to reduce your weight. Men who are overweight produce excess estrogen in their adipose tissue, and that extra estrogen definitely can affect your sperm performance because it's lowering your testosterone levels and your sperm production. So you want to get as healthy and fit as you can. Healthy diet, low cholesterol, low sugar, lots of rich nutrients and vitamins. Again, Jen Strong is amazing for that. We are bringing on board a dietitian as well. So we're going to have an amazing team here to help you with your dietary needs, whether you're male or female. And then finally, you definitely can use lots of vitamins in order to try and sort of stimulate antioxidant therapy to avoid the effects of things that may have happened before or that you're exposed to on a chronic basis through work or diet or whatever the case is. So a lot of those, I mean, there's a long list of vitamins, but a lot of these vitamins are deficient in almost every North American male in studies that have been looked at. And when you replace them, you can definitely see an improvement. We use the YAD pharmaceutical vitamins because they're Canadian. I know the owners, they're really doing a great job. I don't own stock or anything like that. So I want you to know that's a really good vitamin company. They produce great products. They're much cheaper than a lot of their competitors. And we've been very, very happy with the results that we've seen. And we do carry them in our pharmacy for that reason. So for the ladies out there, remember, the guys are equally responsible for this. Fertility tends to be about 40% male, 40% female, 20% both. So that's a great question from whoever asked. If you're a male, I'm glad you asked that. And if you're female, make sure your partner knows they're equally responsible for your successes and your failures.
All my questions are gone. It's just backloading. Bombarded with backloading.
Whoops. Okay, let's go down here. I'm currently at another fertility clinic, but want to come and see you. Do I need a referral to come and see you, or can I just call to transfer files and everything over and set up an appointment? You can call and transfer everything if you're going straight to IVF, because we can actually charge you for that, and then you can come in directly. But I always recommend that patients just get a referral, because then we don't have to charge you, and I would much prefer to not charge you if you're Canadian and you have OHIP. So definitely get a referral from a walk-in clinic or a family doc and then come in and see us. We will definitely guide you through the process. If you can bring your files with you, it certainly simplifies things, and we will take you on board and do our absolute best to help you through the journey. What would you recommend as recovery time after transfer? We have a fertility fact or fiction on that. I don't know if that one's up. Is that up on the website? Yeah, the older one? So you don't need any recovery time. Every single study out there shows that there is actually no benefit to doing anything special after you've had an embryo transfer. But I recommend in general people take it easy for about 24 hours and rest, mostly because I think there's a psychological advantage to it, not because there's a chemical, physiological, or physical advantage to it. I think that if you don't rest, you will always second guess yourself and wonder, should I rest, or did I do too much, or did we kind of overdo it and that's why it didn't work? But if you're resting, you're really never going to second guess yourself, because you're going to say I did everything humanly possible. However, definitely whatever stresses you the least is what you should do. So if you're less stressed going to work, go to work. And if you're less stressed just chilling at home and watching Netflix, I'm watching Ragnarok. I love it, so watch Ragnarok. I mean, do whatever works for you guys. Let me do another one here before we lose them all. I'm on letrozole prescribed by you. The nurse recommended I come in next cycle to monitor to see if I'm on the proper dose. Do I still take letrozole while I go through monitoring? Yeah, for sure. So we want to see if the dose we've given you is actually working to help stimulate your ovary to produce an egg. Typically speaking, if you're taking either Clomid or Letrozole and you're not having a period within 35 days, it probably means you're either pregnant, which would be amazing, or that it has actually not worked to help you ovulate, or certainly not in time. So for some people where we're giving them a reasonable dose and they're not getting the answers that we want, excuse me, or the response that we want, we definitely want those patients monitored so we can watch with ultrasound and blood work to see if the right things are happening. And if not, we can adjust. We can give you more meds or sometimes even rescue that cycle by adding in extra medications, typically injectables, but at a low dose so that you're not losing that opportunity. Okay, back to Instagram. I gotta go all the way back here. Having my FET transfer with you, Dr. Victory, this Friday, February 14th, hoping this Valentine's Day will be the best one ever. Yeah, me too. Happy Valentine's Day to all the folks out there. What is the success rate of IUI with injectables? On average, somewhere between about 20 to 25%. With the new Zymo sperm preparation technique that we're using, we're actually seeing even higher success rates, so it can be quite significant. Our Sarnia clinic right now is getting about a 33% success rate, and that's where we're doing all our IUIs, so it's really, really high. Like, I haven't seen success rates that high before, so this Zymo thing is really doing wonders. Not a fertility question, but do I take high-risk OB patients or just OB patients that do fertility? Okay, so for years now, we have taken pretty much everybody that walked through the door because we really want to help everyone. But in order to help as many fertility patients as we can, we are really only taking our fertility patients that we help conceive. If you need someone for OB, you can certainly text me or message me and I will give you suggestions. We do have a high-risk specialist in town, and there are several in London that can deal with more significant concerns as well. And in many instances, what some people think is high risk is not necessarily high risk. So you may be able to see a normal OBGYN, a generalist, or someone that just has a little bit of extra expertise. I can speak very proudly of many of my colleagues here in Windsor. They are excellent. They do a really good job. It is one of the reasons I stayed in Windsor for my practice. So shout out to all my colleagues in the OBGYN group in Windsor. Everybody's pretty amazing here, and you'll get good care pretty much no matter who you're seeing. Okay, back to Instagram, or Facebook. Do you have?
Facebook one for everyone.
You got? Yeah, sure, fire away.
So I'm a 38-year-old, unexplained infertility. We had tried for 5 years with time intercourse, letrozole, and Clomid. We recently did 3 cycles of IUI with letrozole 2.5 and trigger shot with no success. I had hysteroscopy to remove a poly-P yesterday. I'm going to start letrozole 5 milligrams tonight for IUI number 4. Will the procedure increase the chances of a pregnancy? We are a military family in the US and on the waiting list for IVF. Will IVF be our best option?
Okay, so that's a great question. Thank you for your service in the US. That's amazing. Thanks for being in the military. You guys protect us all, Canada and the US, so that's really noble and amazing of you. So I will say that IVF is always your best option, even if we take the healthiest, most normal, the sperm are wearing Superman capes and the eggs have Wonder Woman gear on. Eggs, we're still going to get a higher success rate for you if we do IVF than you are trying on your own. So IVF is always your best option. Having said that, the main issue for you is that you were doing something initially that probably wasn't that helpful. So we know with unexplained infertility that just taking letrozole or Clomid alone is not beneficial. You have to be doing letrozole or Clomid with IUI. You did mention you had subsequently done that, so that's really great, but now it sounds like there was a polyp, and a polyp can very significantly reduce your chances. So what you really want to be doing is letrozole, Clomid, or injectables with the IUI when there is nothing there. And your unexplained infertility with all the treatments you've had so far should definitely be explored with laparoscopy and hysteroscopy. I'm not sure if you mentioned the laparoscopy there, but if you haven't had laparoscopy, you want to rule out things like endometriosis, previous adhesions, tubal factor, things like that. It doesn't mean that if you're on a long waiting list, you should abandon doing the IUI. Certainly if it's financially viable for you, it's reasonable to continue until you're ready to do IVF. but there's got to be an end game in sight. And there are some studies that say that if you're doing IUI more than 6 times, it actually starts becoming detrimental. So usually 4 to 6 tries is our maximum, and I wouldn't recommend doing more than that. Okay, 2 transfers with lining at 8 millimeters, 9 millimeters plus. The second transfer ended in miscarriage at 8 weeks. I'm very sorry. Sorry about that, guys. Now preparing for third, but having trouble building lining. Has stopped both attempts at 5.5 millimeters. Any advice? That's an awesome question. We haven't had that in a long time. There are ways to increase the thickness of your lining. Vitamins help, including vitamin D and E. We actually sometimes use Viagra. Aspirin can be beneficial at times. And then estrogen approach is important. So some people are on oral, sometimes you need to use vaginal, some people respond better to patches than they do to the pills. So there are a variety of techniques that can be used. Sometimes we even just go natural and you do better in a natural cycle than you do otherwise. So there are a variety of techniques that can be used. Make sure you're discussing it with your REI, and if they're not getting the result that you need, shout out to me and I'll do what I can for you to guide you through the process. You got one there?
Yeah. Oh, no, it's actually, I answered it. I typed it.
Okay. In Duo Stim protocol, would medication dosing be the same in the follicular phase stim as in the luteal phase, or would there be adjustments? So the studies suggest that you may need a little bit more in the luteal phase, the second stim, but then you also produced a few more eggs in that phase. So we'll probably play it by ear and see how you're doing. We would most likely start with the same or just a little bit more in the second stim, and then if we needed even more, we'll add even more. There is a maximum though, beyond which many studies have shown that there's no benefit to exceeding. Backloading costs sounds helpful. I need you guys to tell us what to do. So please, 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 regardless of what social media platform you're on, we need to hear from you and let us know about this. I'm hearing some more yeahs. Yeah, yay for sure. Backload. Oh, it's good. Wow.
Make sure they put likes in.
Yeah, and lots of likes. Those of you who like the backload idea, send out tons of likes. We want to see a whole flurry of likes and hearts and all that stuff. Okay, and share and ask other friends of yours and tell everybody else. You know, the more people that can answer this for us, the better it is for us. Okay.
Question.
Yeah.
I'm still experiencing cramping 24 hours after my IUI. Should I be concerned?
No, it depends on how many eggs you've released, and it can be crampy, especially if some of the eggs had some bleeding in them. So I wouldn't be worried at all. As long as there's no fever, there's nothing to be worried about from the cramping. Don't take ibuprofen, just take Tylenol, warm bath, meditate, like gentle things to help you through that. I've gained weight since starting IVF to now, about 10% of my body weight. Is this concerning? My diet has been normal and I exercise regularly. I'm worried it may complicate my FET pregnancy. It depends on what you started at. I mean, if you started at a normal body mass index and you've gained 10%, that's probably not a big issue. If you started and you were overweight, or even in the obese category for BMI, then yes, that's definitely an issue, because we know for sure that the higher your BMI is, the lower your success rate and the higher the complications. So it can be a factor, but it depends on where you started and where you're ending up. Is it okay to keep using Pregvit if you are not pregnant? Yeah, absolutely. Pregvit's a very good a very good prenatal vitamin, and you can use it even when you're not pregnant. We especially recommend it to our lactating moms. You got one? Yeah.
I'm working on reducing breastfeeding, hoping to get pregnant again soon. Should I start taking aspirin while breastfeeding?
No. Wait until you're done your breastfeeding before you start aspirin. Yeah, it probably would have a very minimal concentration getting into the baby, but there's really no reason to do it until you're actually ready to try, because you can start aspirin the same month you start trying. So don't do it while you're breastfeeding. I got more backloads, man. This is really interesting. I think the backloading fee would reduce the stress. I was just diagnosed with PCOS on top of my endometriosis, and now I am late on my cycle. Okay, well, if you have PCOS, you may have irregular cycles. Make sure you don't stay irregular. If you're trying to conceive, make sure you're seeing a physician who can help you, because it is kind of difficult to conceive with PCOS if you're not regular. You got one?
Yeah. Can letrozole or Clomid affect the results and reliability of an ovulation test?
Can letrozole or Clomid alter the reliability?
Effects.
No. Well, yes, you're much more likely to ovulate if you're taking letrozole or Clomid. So in that sense, yes, but it's not going to mess up a test result. In other words, you're not going to get a false positive just because you've taken letrozole or Clomid.
Yeah, reliability.
Yeah, it should be fine. I feel like, oh, that's okay. There's all sorts of stuff about the embryo. Maybe have like a bucket less than 5 or 10 embryos, more than 10. Yes, I think we will be doing that. Does our pharmacy accept deliveries, prescriptions internationally? That's an awesome question. I'll ask tomorrow. I'm sure there's regulations, but we will ask Kinga or Janine Peretti, who are two of our leads here. So I will find out and we will post it. We got 2 minutes left, actually probably about 3.
This spot's off.
Does endometriosis continue to grow after giving birth while breastfeeding? Okay, so while you're breastfeeding, your prolactin levels are really high because you're producing breast milk, and your estrogen levels, when your prolactin levels are high, are really low. If your estrogen levels are low, you are kind of starving your endometriosis, so you really should not be getting a lot of endometriotic growth while you're breastfeeding. And this is kind of consistent with what we find clinically, because most women who are breastfeeding do not feel the same amount of pain that they have when they're experiencing pain from their endometriosis. So breastfeeding is very salutary, meaning beneficial in a healing sort of way. You got one?
No.
No, okay. Where can I message you to get that information? I was a fertility patient, had my daughter IVF, but now surprisingly, oh, you did? All right, we answered that one. Awesome.
There's really tons on the other way.
No, I've answered all of those. Okay, so back to Instagram. What's the name again? The name of what? Duo Stim is for the thing that was our fertility factor fiction. Okay, 27 hours after my trigger shot, I was in pain for 2 hours on the side with my follicle. Is that because it was releasing the egg? Yes. Why did it hurt for so long? It hurt around my ovary, and then it ends. Yeah, so you may have released more than one egg, or it may have been a bigger egg. Sometimes you can bleed into the egg, so that can all be kind of uncomfortable and painful. Sorry if it's uncomfortable. Like I said earlier, warm bath, Tylenol, no ibuprofen, Advil, Motrin. What's the best suppression birth control for endometriosis before IVF? If you have endo before IVF, you should be doing 3 months of Lupron with letrozole, not birth control, because 3 months of Lupron with letrozole, which was just released recently, we have switched all our patients over, increases your success rate substantially. So you don't want to be on birth control, you want to be on Lupron and letrozole. Okay, last question, folks. I've been trying to get pregnant for 8 years. I'm 37 years old. I'm considering IVF, but it's so expensive. Can I have funding from any organization to help me? I live in Winnipeg. You might be able to. I don't know about the funding in Winnipeg. Ontario has a program. I think Winnipeg actually offers a tax credit for its patients doing IVF, so you should explore that. Okay, that's a wrap on Fertility Factor Fiction this week. That was a great week. I really loved the topic this week. I'm going to try and bring you lots more exciting topics. If you guys have one you want, I'll be back with you next week. Next week is going to be Tuesday because it is Family Day weekend, and I am going to see my very beautiful son, Nassim, who just celebrated his birthday. Thank you to all of you who wished him well, and thank you to all my kids, my wife, who are amazing and put up with me not being home much so I can help you guys out. Love you all. Thanks again to Tarek from IG Strategies Group, and we will see you guys next week.